Welcome back. Today we're going to be discussing Chapter 20, which covers allergic reactions. I've said it before, I'll say it again. The EMT's ability to recognize anaphylaxis and administer epinephrine appropriately is one of the few times that you single-handedly, without the assistance of any other medical professional, can save a life. So this is very important that we understand allergic reactions down to even the cellular level, and really is important that we recognize the signs and symptoms that we will see that indicate that we really need to give that epinephrine, because epinephrine is not a harmless drug. It's very rough on the body, but when needed it is life-saving. So we really do need to discuss this in detail as to what's happening in the body, why we give the epinephrine, and what we're looking for to actually give this. And we really only have the one topic to cover today, which is allergic reactions. So without further ado, let's dive on in. So some terminology that we should be aware of is an allergic reaction is a body's natural response to a foreign substance in you. So an allergic reaction is something that is actually healthy to do. It's a exaggerated response to a small thing in you. So we do need to know that the allergic reaction is an exaggerated natural response to a foreign substance. And then an allergen is whatever substance triggers that exaggerated response. So again, this is something the body wants to do and it should be doing. This is what keeps us not sick all the time. This is our immune system reacting naturally, but this is just a tenfold reaction that will cause an actual allergic reaction. So I'm sure you guys have heard at one point someone telling you, oh, you're not really allergic to bees until after you've been stung once. There is a little bit of truth behind that. There are people that will be exposed to an allergen and have a massive response the first time. But for the vast majority of people, the first exposure, your body is learning how to react to the allergen. So when you first get exposed, your body forms antibodies. So it's pretty much instructions on how to react to the substance the next time that we see it. So this is how we can attack this substance to fight it off. Well, this is something that we try to trigger when we give vaccines. So if you get a flu vaccine, our goal is to have your body form antibodies so that your body knows how to fight off an actual flu virus when it sees it. Same thing that happened with the COVID vaccine is they had messenger RNA that told your body this is how we need to build the antibodies to fight off COVID. So once we have the antibodies in your system, their job is to attack whatever foreign substance comes in. Their job is to kill off whatever comes in again. Antibodies are very specific, so they will only fight the allergen or infection that they were formed in the response to. So that's why we need to get boosters of some vaccines, because these antibodies are only designed to fight off one specific strain of a particular allergen or virus or whatever we're talking about. And if that virus or allergen changes at all, then the antibodies won't be nearly as effective because they're only trained to fight that one specific allergen. So once we have those antibodies, when we have further exposures, the antibodies will combine with the allergen or whatever it's attacking, and that leads to a release of histamine. Histamine is a very important hormone in your body. We're going to talk about it in the next slide. So I'm sure you guys have heard of histamine before, mainly medications called antihistamines like Benadryl. But histamine is a very, very, very important hormone in your body, and its job is to cause things that will assist you in removing whatever is attacking your body. So some of these symptoms you're going to see as pretty familiar, whether you see it or whether you actually experience the stuff. First thing that it will do is it stimulates itching. It will have you scratch that area because it's hoping that you'll scratch that allergen off of your skin. It stimulates increased mucus production in sneezing and coughing. The increased mucus production causes the mucus to surround that allergen, and then you sneeze and cough to get that mucus out of you, so you're expelling that allergen out of you. It causes bronchoconstriction. If you have an allergen that's trying to get into your body through your airway, it constricts your bronchioles, makes it harder for that allergen to get further down into your lungs so that it can't get into your alveoli and go into your bloodstream. So it will constrict those bronchioles, cause mucus to attack that allergen, and then sneeze and cough it up. It also increases blood flow to the area where you're having the problem. So that will bring a lot more white blood cells, a lot more antibodies to come fight whatever is trying to attack your body. And that increased blood flow causes swelling. We also see vasodilation and increased vascular permeability. The vasodilation allows for more blood flow to sit in one area, and then the vascular permeability allows fluids to shift in and out of the vasculature a lot easier, so that things can get in and out to fight whatever you're seeing. So all of these are very, very, very helpful things when we have an allergen hit our body or some sort of thing attacking our body come in. So histamine is critical for removing these things from our body, and it's very, very useful most of the time. But if we have an exaggerated response to where all this stuff comes up a lot more powerful and then we spread it through our entire body, that's where we have a lot of the issues we see with allergic reactions and anaphylaxis. So vasodilation in a localized area is very good, but if you have vasodilation throughout your entire body, that is very bad. That will drop your blood pressure significantly. Same with like bronchoconstriction. Bronchoconstriction in a localized area of your lung, just to try to stop an allergen getting further down, that's very good. You constrict the bronchioles, you cough once, you get the allergen out. If you have widespread bronchoconstriction, that's where you have a problem. That's where you can't get air in and out of your lungs. So you can see how all this stuff localized is great, but on a widespread scale, this causes all the problems that we see with full-blown allergic reactions and anaphylaxis. So going into anaphylaxis. So anaphylaxis is a form of distributive shock. That's why people might say anaphylactic shock, because it triggers a shock response that happens to be a distributive shock. So it is a very severe and life-threatening thing to happen to you, and it's the later stages of an allergic reaction. This is where it starts to affect the entire body. By definition, anaphylaxis is an allergic reaction that starts to involve 2 or more body systems. And that is the pure definition, but when we get into the point where we're actually treating it, we are looking for a few other different things, so we're going to talk about that in the next slide. So the dangerous things that we see in anaphylaxis is rapid dilation of the blood vessels that causes profound hypotension. That's because histamine causes vasodilation. So you're going to see a lot of that, which is not great for us. You also see airway swelling. That's because you have the vasodilation combined with your increased vascular permeability, which causes widespread swelling, and specifically swelling that's found in your airway. That will cause an airway obstruction, so you can't get air in and out of your lungs. So that's, again, very bad. And then bronchoconstriction, because histamine causes vasoconstriction. So if you have that widespread, you not only have airway swelling, so it's hard to get air around in your upper airway, but you also can't get air into your lower airway very well because of the constriction. So all 3 of these are very life-threatening things to have happen to you, and oftentimes in anaphylaxis we have all 3 happen at the same time. So that begs the question, when are we treating these patients? When does an allergic reaction get to the point where we have to intervene in this? And we have 2 key things that we're looking for. If you have one of these 2 things, then we should be treating the anaphylaxis. So first one is when a patient has a severe respiratory compromise. So 3 things that you're looking for that are stridor, which again is a high-pitched upper airway sound that's indicative of an upper airway obstruction, so the swelling is causing obstruction. If you see airway or facial edema, so swelling in your airway or around your face, and then any signs of inadequate breathing. So those are the 3 respiratory compromise things that you look for. If you see any of these, then we should be treating the patient. For the cardiac side, you're looking for profound hypotension. So this is all relative. If you have a patient that has profound hypotension, but they don't have any signs of an allergic reaction beyond that, then don't give epi to these patients. You need to be suspecting a massive allergic reaction happening, causing anaphylaxis, which is then causing the hypotension. So keep that in mind. So any of these causes right here are reasons to give epinephrine and treat the anaphylaxis, but make sure the patient actually has anaphylaxis going on before you give epi. Just because you see this in a patient, just one of these things, doesn't mean that they necessarily have an allergic reaction going on. So, be smart. Again, look at the whole patient picture. Make sure that they're actually having an allergic reaction. They're not just having hypotension because they're dehydrated, and then you give them epi because, oh, their blood pressure is 70/30, they need epi. Make sure they're actually having an allergic reaction. So some common allergens, none of these should really surprise you guys. You have insects, so like bees are a very common one. Certain foods are very common, certain plants, certain medications. Some people are allergic to dust or to soaps or to makeups or to shampoos or to laundry detergents. So pretty much anything can cause an allergic reaction, but these are some of the more common ones that you see. One thing that used to affect EMS a lot more was a latex allergy. Latex allergies were especially problematic because they tend to develop after someone is in contact with latex repeatedly for a long period of time. So if you had latex gloves that you're putting on every single call and you worked for years, you would generally develop a latex allergy over time. So that's why we have shifted in EMS to using nitrile gloves. And really, healthcare as a whole has shifted to using nitrile gloves because they're finding a lot of people were developing latex allergies. So that's kind of a thing of the past, and that's what caused our shift to nitrile gloves. So one of the dangerous things about allergic reactions is they're very, very unpredictable. You can usually get some sort of indication as to what's going to happen if you ask them about the patient's previous history with allergic reactions, but no 2 reactions are going to be identical, and that's also gets very dangerous to assume that something's going to be mild because any one reaction can become severe very quickly. So typically, severe reactions will take place very quickly, like within seconds or minutes after the allergen hits, but it can be delayed. It can be upwards of 30 minutes or an hour before an allergic or severe reaction actually takes place. So that's where we have to be very, very careful. Just because they are having a mild reaction at the start doesn't mean that they're not going to progress to having severe symptoms very quickly. So it does, like I said, it does help knowing their history. You can say, hey, when you've had these reactions before, how they turned out, what usually happens to you. If they say, oh, I take some Benadryl, I'm fine every single time, my level of concern is a little bit less than someone who is having mild symptoms and says, oh, every time that I am exposed to this allergen, I have to be sent to the hospital, I get multiple rounds of epinephrine, I have to be treated for several days for this. And so just because they're experiencing mild symptoms now, I'm going to be a lot more suspicious that they're going to develop severe reaction later. So their history does help, but it's not definitive. Just because they've never had a severe reaction before doesn't mean that this will not be a severe reaction. So some signs and symptoms that we look for in allergic reactions. First is pretty common to see. We have itching. Then I always butcher how to say this, urticaria, which is the medical term for hives. You might have red skin, and that's from the vasodilation and increased blood flow. You will have swelling of the face and airway, and then warm, tingling feeling in the face, mouth, chest, feet, and or hands. Again, that's from the increased blood flow and vascular permeability and some vasodilation that causes all that stuff. So taking a look at this patient. Does this patient look like he's having an allergic reaction? I definitely think so. You can see the redness in his face. You can see swelling in his eyes. It looks like there's some redness in his neck. The question comes, are we giving this patient epinephrine? So by pure definition, yes, you can, because you do see facial edema. But I want to know a little bit more about this patient first. I want to know, how are they breathing? Are they moving air in and out just fine? Are their lung sounds clear? Is their blood pressure okay? If you see all that stuff where everything is acting normally, I might hold off on epinephrine a little bit, and I'd actually get ALS involved to give less invasive drugs like Benadryl to this patient. But you need more information. If he has any sign, like he has a little bit of stridor or wheezing going on, then yeah, we should be giving epinephrine to this patient. Here's a great picture of hives. So again, the urticaria. This is increased blood flow causing a little bit of swelling, which also causes a lot of itching to the area. This is, again, a exaggerated histamine response. Some more signs and symptoms of allergic reactions. As far as respiratory goes, you're going to have tightness in your throat or chest, difficulty breathing, cough, rapid labored breathing usually, some hoarseness, a muffled voice, and that's because we have the swelling right around our vocal cords, stridor for upper airway sounds, and then wheezing for lower airway sounds, or actual lung sounds. So you might have both. Then for cardiac, we have increased heart rate and decreased blood pressure. Increased heart rate is for compensation, and then decreased blood pressure because of the widespread vasodilation. Generalized symptoms that we're going to see are itchy and watery eyes. You might get a headache, a runny nose, and a lot of anxiety. And anxiety usually comes from the inability to breathe. If you feel like you can't get air in and out, you're going to become very, very anxious. Again, shock. We've gone over shock quite a bit, so none of this should be new. You'll have altered mentation. You'll have flushed and dry skin, or your classic pale, cool, and clammy skin. The flushed and dry skin is just because of the histamine reaction, but if you truly fall into shock where you have poor perfusion and you have widespread vasodilation, that's where we're going to see the pale, cool, and clammy skin start to come on. You might have some nausea or vomiting, especially dependent on the allergen that you're exposed to. Especially if you ingested that allergen, then you're going to probably have some nausea and vomiting. And then you're going to have your compensation measures, so increased pulse, increased respirations, and decreased blood pressure. None of that should be new to you guys at this point. So, like I said, it's critical that we know the difference between an allergic reaction and anaphylaxis that we have to treat. We are going to see a lot of those signs and symptoms that we just discussed with most allergic reactions. Almost every allergic reaction is going to have at least one of those signs and symptoms appear. A lot of them are going to have multiple of those. So we really need to remember that we are not treating this until we have respiratory and or cardiac compromise. So we're looking for the inability to move air effectively and the widespread vasodilation causing hypotension. Those are the key things that we're looking for to give epinephrine. If they don't have those, again, ALS intercept to give less invasive drugs is definitely indicated. And if they have, or if you are going to give epi, then you need to have an ALS intercept anyway to evaluate their cardiac status, because again, epi is very hard on your body, especially your heart. So these are calls where getting ALS started is a good idea regardless, because if it's not as critical, ALS can give less critical medications, and if it is critical, you want ALS to follow up care with the patient. So our patient assessment is pretty straightforward. you want to do your primary assessment, so make sure your ABCs are intact. This is where you might find an issue with your ABCs. So this is where you might see the airway swelling causing ineffective breathing. So this is where you want to be giving your medications before your full secondary assessment, because your medications is what's going to affect your ABCs. That being said, make sure that, again, they're actually having an allergic reaction. So just because you see the inability to breathe well doesn't mean that it's an allergic reaction. So you might need to ventilate them for a minute until you get far enough down into your secondary assessment to determine that, yes, this is an actual allergic reaction. So take everything relative. This is where doing an assessment in class and going down the sheet is a lot different than what we do in person, because in person this goes a lot faster than the step-by-step things on the sheet where we have to say every single thing out loud instead of doing it in our head. So your secondary assessment, find out if they have a history of allergies. That does usually help, because if they do have a history and they were exposed to it, then that will help narrow down that this is probably an allergic reaction. But just because they don't have a history of allergies doesn't mean that they aren't having an allergic reaction. They could have been exposed to something that they didn't know they were allergic to. So if you do think it's an allergic reaction, find out what they're exposed to. Sometimes it is unknown. You can have all the classic signs and not have any idea of what they were exposed to. That's okay. But if you do know what they're exposed to, find out how they were exposed. If they have a history of bee stings and they got stung by a bee, then they were exposed via injection from the bee sting. If they are allergic to carrots and they ate a carrot, then they ingested the allergen. So then you look at their signs and symptoms. Again, refer back to all the signs and symptoms that we just covered. Find out how it's been progressing. Has this been a fast onset? Has this been a slow but progressing onset? And then find out if they have done anything before you got there. Did they take Benadryl on their own? Did they take their EpiPen? And again, that's very important, because if they took their own Epi, then we need to contact medical control before we give a second dose of Epi. Move on to your baseline vital signs, and then do the rest of your sample and OPQRST. Then you perform your interventions. Again, this in real life is probably going to be done a lot sooner, the intervention part, just because a lot of this stuff is very obvious when you see it. If they come up to you and say, I'm allergic to this and I got exposed to this, I can't breathe, help me, and they are legitimately not breathing well, and you see all the indications that we need to give Epi, you're going to be giving Epi pretty darn quick. You're not going to say, oh, well, let me do your blood pressure first and do all these other things and get down through all my sample history first. You're going to be giving Epi pretty darn quick. So take that all into account, and the reason why we can do that is because Epi is going to fix our problem with our ABCs. And our ABCs, as you know, is our stop and fix zone. So take all this very relative. Again, our assessments in class versus what we actually do in the field as far as it comes to allergic reactions do vary a little bit. And that's just because in class we need to hear you say all these things out loud. In the field, you're doing a lot of your assessment in your head, so you can do it a lot quicker. As far as patient care, make sure that you protect their airway and breathing. That's what this is all about. So we're giving oxygen pretty quickly. That's only if we have a severe reaction. A lot of this that we're talking about is for severe reactions. If you have a mild reaction, you don't need Epi, you don't need oxygen, you usually don't need ventilatory support. And by mild, I mean like someone who has seasonal allergies. If you have seasonal allergies, do you really need oxygen all the time when you're having a seasonal allergy thing happen? No. So we're talking more of the anaphylactic side when we're talking about oxygen administration. If they're not breathing or not breathing adequately, then remember that we do have to provide positive pressure ventilations. Give your epinephrine if indicated. Again, our adult dose is 0.3 milligrams given intramuscularly, and our pediatric dose is 0.15 milligrams given intramuscularly. If the patient is not wheezing or showing signs of respiratory distress or shock, that's where we're not giving Epi on standing order. We continue through our assessment. And then we contact medical control and talk to them if you want to still give epi. But usually if they are not showing signs of respiratory distress or cardiac compromise, then we're usually not wanting to give epi. If you do give epi, make sure that you record when you gave it. Make sure that you transport the patient. Epi will usually fix all these complaints. But there's two things that we need to keep in mind. First, like I said, epinephrine is a harsh drug on your body. These patients usually need to have cardiac monitoring for about 24 hours after you give epi, just to make sure that nothing's going to go on with their heart from this artificial administration of epi. Also, epi will take care of the symptoms for a while, but if the allergen is still in your body and the epi wears off, you can have what's called a rebound reaction. The rebound reaction is usually much, much worse than your initial reaction. So if the initial reaction was so bad that you had to give epi, a rebound reaction is going to be very, very bad, like to the point where someone might stop breathing. So if you had a patient truly in anaphylaxis that was given epi, you have to take them to the hospital. So if they're refusing, please explain to them all this stuff. They technically don't lose the right to refuse care, but you need to be a good patient advocate and explain why they should be monitored at the hospital. And then after epi administration, make sure you're reassessing very, very frequently. Usually you want initial reassessment after about 2 minutes, and then at least every 5 minutes thereafter, just to make sure that the body's doing okay. So a reminder, epinephrine from pharmacology, it is a sympathomimetic, so it mimics your sympathetic nervous system, so it will increase your heart rate, it will vasoconstrict, and then it will bronchodilate. So those are the three main effects of epinephrine, and the epinephrine is given because we have vasodilation, so vasoconstriction will fix that, and we also have bronchoconstriction, which bronchodilation fixes that. So that's why we give epinephrine, and that's why it works very well, because it counteracts most of the major things that we see in allergic reactions. Again, our dose is 0.3 milligrams for adults, 0.15 for pediatrics. It's given intramuscularly, and you can only give it once on standing order. Going into a little bit of chapter review. So the signs and symptoms of anaphylaxis result from physiological changes, vasodilation, bronchoconstriction, leaky capillaries, and thick mucus. By quickly recognizing the condition, consulting medical direction if you need to, and administering the appropriate treatment, you can literally make the difference between life and death for these patients. In an allergic reaction, the body's immune system overreacts to an allergen and causes potentially harmful side effects. Anaphylaxis is a severe systemic form of allergic reaction. It is a life-threatening emergency. Remember, EMTs must use assessment to differentiate a localized allergic reaction from a systemic anaphylactic reaction. Epinephrine is useful in anaphylaxis because it constricts dilated blood vessels and opens bronchial passages. Remember, epinephrine has potentially dangerous side effects and should be used only in the event of anaphylaxis. So a 24-year-old male ate a meal that believes contains shellfish. He is allergic to shrimp. He is sweating and nervous. He appears to be breathing adequately. You do not know any wheezing or stridor. His face is slightly red. His pulse is 88, strong and regular. Respirations are 24. Blood pressure 108 on 74. Skin is warm and moist. Should you administer epinephrine? So, no. You should not give epinephrine to this patient because he's not showing signs of respiratory or cardiac compromise. So this is a mild allergic reaction. This is where we might want to get ALS involved to give less critical medications to the patient. So this is a perfect example of being able to find out from information, is this patient in compromise or not in compromise of respiratory or cardiac. So that brings us to the end of this chapter. It was a relatively quick chapter. That's because we only talk about one thing, but that is a very important thing for us to know. So make sure that you have this down pat. Make sure that you know all the indications for giving epinephrine, and when we do treat and when we don't treat these patients, and why we're doing that. So, and it is a very important thing for us to know, and it's a pretty fun topic for me. I really like talking about allergic reactions, and it's like I said, a chance where an EMT by themselves can make a difference between a patient living or dying. So it is a very important fundamental thing for us to know as EMTs. So until next time.